Oh, so I want to welcome everybody here. This is Therapy Thursday. So this is our online uh, informational sessions that we're doing here at UNC Health through the therapy services, particularly through our community engagement committee, providing a service to our community and to people really anywhere because it's virtual. So it's information that people can use, and especially in this time where we're not able to see everybody face to face as much, it's really nice to be able to provide this kind of service to those who are still kind of stuck at home. So, Therapy Thursdays, we're doing this every other Thursday, the first and third Thursdays of the month with varying topics. Today, we're very excited. This is a topic that people have asked about in the clinic all the time, and that I end up finding time and time again. And it's really, really important as we get into this age of so many people having chronic pain, and things are healing, but that pain is still kind of lingering and still around, and it's important to know why. So today we have Sam with us, who has put together a great presentation for us on pain explained. The one thing I would ask for everybody is that we do want to encourage you to ask questions, but what I would do is I would like everybody to please go ahead and mute themselves if you haven't already. Sam's going to give his presentation. If you want to put some questions in the chat, as we go through, we will entertain them at the end of the presentation. We will also make the slides and recordings available if you are interested, and we'll go from there. All right. So without further ado, Sam, I'll turn it over to you, and it is all yours.
All right, thanks, Evan. Audio quality is still good?
Yep.
All right. Last time I was on one of these WebExes, my audio quality was terrible and there was all kinds of feedback and I sounded like a screeching digital kind of demon. So I'm glad that is not happening now, hoping this goes better than last time. So my name is Sam Lucier. I'm a physical therapist with UNC Therapy Services at the Meadowmont Wellness Center. I've been here for a couple years now, and obviously one of the things that we treat in the clinic a lot is pain. So I think it's really important to have a good understanding of what pain is and what causes it and all the other factors surrounding it. In addition to talking about pain, I want to talk about this concept of becoming resilient as well, because I think it ties in very nicely to becoming a more confident human being who's able to tolerate all the stresses of daily life on this planet. So I will go ahead and start with my objectives here. So the few things that I want to touch base on throughout the presentation. First, we need to talk about why pain is such an important topic. Obviously, it's relevant to everybody. Everybody experiences pain, but I think there's certain misunderstandings about what pain is, and how we poorly manage it oftentimes in this country. We have to define pain and understand what it is and how our body produces it. I want to talk about what is different about chronic pain as well, how that differs maybe from an acute pain, such as stubbing your toe or cutting yourself, something like that. So what's different about chronic pain? As a physical therapist, I want to discuss just briefly kind of things that we do to manage pain, looking at it from this perspective, and then finally talking about becoming a more resilient human. So why do we need to talk about pain? Well, there's a lot of pain in the United States. Estimates range from between 11 and all the way up to 40% of Americans live with chronic pain. Best estimates around 20%. That's 1 in 5 adults, or maybe 50 million people who have pain almost daily or almost daily, and this drastically interferes with their quality of life and their function. All of this pain is costing us lots and lots of money. Estimates are that we spend $560 billion every single year on pain. And these are direct medical costs. These are costs because of lost productivity at work and also disability programs. I did the math, and that comes out to about $2,600 per adult in this country per year just spent on pain. So with all this pain, what are we doing to treat it? We're taking a lot of opioids. So a very staggering statistic that I've come across is that while we only constitute 4.6% of the world's population, we consume 80% of the opioid supply in the world and 99% of the hydrocodone. So we're literally taking all of the pain medicine that the world can produce. If you can see where I'm going with this, you have to imagine that all these opioids are leading to a lot of deaths, unfortunately, as you can see from these headlines. So everyone, I'm sure, is aware of the opioid crisis in America. It garnered lots of headlines over the past few years. Not so much recently. We have other news to tackle, but this has been really big news over the past few years. So while this presentation isn't necessarily about the opioid crisis, I'm bringing it up to illustrate that we are not handling pain well in America. I don't necessarily think the opioid crisis is the problem. I see it more as a symptom of the fact that we don't understand pain and we don't manage it well. So moving on, we have to define what pain is if we're going to talk about it. So there's a recent definition that just came out. The International Association for the Study of Pain just updated their definition for the first time in 25 or 30 years. So pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. You can see I bolded a couple of the words in that definition, which I think are important to note, that pain does not necessarily mean there is tissue damage, and this experience can resemble an experience that is related to an injury or some kind of tissue damage. Some other important notes that they added for this updated definition is that pain is always a personal experience that is influenced by several factors, such as biological, psychological, and social factors. So I hope to touch on all of those factors throughout this presentation. So this is a funny and kind of strange illustration, but I'm bringing it up because this is one of the more modern theories of what pain is. So this came from Descartes, the philosopher, all the way back in the 1600s. So I'll just kind of run you through what his theory of pain was. And it kind of makes sense on the surface, but we'll run through it. So say you step on a fire, step on a tack, something like that. Descartes thought that once you had some damage on your skin or in your body, this would pull on a wire. That wire was a nerve cell. By pulling on that wire, it connected all the way up to your brain, and it rang a bell, is the way that he phrased it. So obviously a very simplistic view. I think we know a lot more about anatomy now. But the bottom line was you step on something, pulls a wire, activates a bell in your brain, and you get pain. Fast forward all the way up to the 21st century, and this is more of what we understand pain to be. So it's a highly complex neurophysiological process that I am far from being fully qualified to talk about in detail. But I'm just bringing up these images because we now know that it is so much more of a complex experience, so much more than just stimulus, pulling a wire, pain. So hopefully throughout this process, I'm just going to touch on some of the basic points so we can have a better understanding of pain. It's been shown that just having a basic understanding of what pain is can actually help reduce pain in acute pain and chronic pain alike. So I'm just going to go for a brief kind of primer on the neurophysiology of pain. The details aren't necessarily important, just kind of the overarching ones. So we start with nociception. Nociception is the neural process of translating a noxious stimuli, so that could be chemical, mechanical, or thermal, and taking that stimulus and translating it into nerve signals. So if you see in the middle of the screen, that noxious stimulus triggers these first order neurons that go to the spinal cord and then go up to the brain. That's pretty much all that we need to know about this. It's important to note that nociception is not pain, it is just translating a stimulus into a nerve signal. So after nociception, these signals go up through something called the spinothalamic tract. Again, all of these words are not necessarily important. I just want to give a brief overview kind of what the process of this transmission of the signals look like. So it goes from your arm, your leg, anywhere in your body, goes through some nerves, goes up your spinal cord and into your brain. Along the way, it passes through your brainstem, your midbrain, and then all the way up to the outer parts of our brain where we become conscious of it, where some of our sensory and motor pathways are. It's really important to note here that the spinothalamic tract, which carries these nociceptive signals, interacts with many, many areas of the brain. So this is where it gets kind of complicated and gets kind of interesting, in my opinion. So it's important to understand that pain is so much more than just a sensation. It is an entire experience. Again, all the words of these brain regions are not necessarily important, but if you look through some of them, you'll see that a lot of the regions responsible for producing the experience of pain are also responsible for so many other functions of the brain. Things like thoughts, emotions, fears, even memories, our conscious awareness, pretty much anything that deals with anything is related to pain. So we can start to see how it's so much more of a complex process rather than just a wire going straight into a brain and causing pain. So next, I want to bring up just a couple examples for that it really illustrate how complicated pain is and how pain is different for so many different people. So this study involved several adults where they actually gave them a painful stimulus. It was a noxial thermal stimulus is what the paper says, which means pretty much that these researchers were just burning people and asking them how they felt. I don't know how much they paid them to do this, but I hope it was a decent amount. What they did was they looked at the functional MRI readings of people when they were undergoing these stimulus. So a functional MRI just pretty much tells you how active different brain regions are. So they were focused on the brain regions involved with the production of pain, the same kind of areas that we saw back in this slide. So what they did, they gave everyone the exact same stimulus, the exact same temperature on the exact same area of their body, and they asked them to rate their pain on a scale from 0 to 10. As you might expect, some people said 1, some people said 5, some people said 10. So there was a really, really wide variation in what people reported in the pain levels that they reported. Not so surprising. What's really interesting is that there was a really strong correlation in the activity of the brain regions responsible for producing pain and the amount of pain that a person reported. So if a person reported a 10, brains shown on the left, a significant increase in activity as compared to the people who reported pain of 2 or 3. And this is the exact same stimulus. So that's really interesting that people can have the exact same signals coming from their arm up into their brain, but they have a completely different experience. Another example of how different sensations from the body or different injuries can be handled completely different in the brain. If you look, there's a lot of statistics on that column on the right, but I pretty much just want to illustrate that research consistently shows throughout the body that there are quote unquote abnormal findings throughout people who are completely asymptomatic, meaning they have no pain, their function is fine. They never would have known that they had these things if they didn't sign up for the study. So if you look on the column on the right, you see that even 20-year-olds have, if you MRI a group of 20-year-olds who don't have any back pain whatsoever, 37% of them will have disc degeneration. Go all the way up to people who are 80 years old, 96% have disc degeneration, and these are people who have no pain whatsoever. Same thing goes with bulging discs. These are things that would be pretty scary if you heard on an MRI that you had a bulging disc, but in reality, these things are normal for people that don't have any pain whatsoever. There's a good chance that most of you listening have a bulging disc or disc degeneration, and you would never know. And in a sense, it doesn't matter too much. Other studies have shown, so if you look at the second couple bullet points on the left here, they wanted to see over 10 years if you had these findings on MRI, such as a bulging disc or things called spondylolisthesis, They wanted to see that over the next 10 years, were you more likely to develop pain? And this was not the case. So they found that baseline MRI results were not associated with low back pain during the following 10 years, meaning that MRI findings cannot predict future low back pain. I just want to give a disclaimer on this too, because MRIs are a very important medical tool that we use. And if it's suggested that you were to get an MRI, you definitely should do so, because MRIs can be really important to identifying serious disease processes, like cancer, infections, things like that. When it comes to bulging discs or disc degeneration, I would argue that those are not really important findings on an MRI. So how can we have all of these exact same injuries and stimulus but completely different experiences in our brain? Well, our brain takes care of that by doing something called descending pain modulation. Again, the neurology behind this isn't too important. It's just important to know that the brain plays a huge role in controlling our sensations and our experiences of pain. So at the spinal cord, there's something called the gate control theory, where neurons in our spinal cord can actually turn off signals coming from our periphery, from our arms or our legs. So these signals won't even make it to the brain because the spinal cord has determined it's not important for the brain to get that information. In the brain stem, there's things called on and off cells. And basically what happens there is an on cell will turn up the volume of that pathway coming to your brain. So if your brain thinks you have to pay attention to something a little more, it's going to turn up the volume on the on cells. Off cells do exactly the opposite. So if your brain determines, hey, we don't need to know this information right now, it's not important, we can turn down the signals coming up from our arms, legs, our body. Where it really gets interesting is the periaqueductal gray. And this is a region where a lot of different brain regions connect to. So brain regions involved with all of our fears, anxieties, beliefs, and memories, things like culture, what do we understand pain to be? They all connect to the periaqueductal gray. And this is pretty much the drugstore of the brain. So this is where we find all of our pain-relieving chemicals. The reason why we can take opioids, cannabinoids, and serotonin and feel better is because our brain actually produces them ourselves. And the periaqueductal gray is responsible for releasing them when it determines it's necessary. So I think a good analogy to look at kind of on the image on the right is like a big soundboard where there's dials, knobs all over the place, and our brain can control exactly how much volume is coming from different areas of the brain to control our experience. So if you were to hear someone say this as you're walking down the street, or hear a medical professional tell you, oh, I lost this. Here we go. Is that back up? Okay. If a medical professional were to tell you it's all in your head, you might be very offended, but in fact, it's true. Pain is created by the brain. It is not created in your body to separate it that way. So no matter if you stub your toe and you feel pain, or if you've had chronic persistent pain for 5 years, it is all created in your head. Pain is essentially a protective mechanism and a survival mechanism for our body. So the basic kind of framework on the right here is this. So your brain takes information from your environment, from tissues in your body, and it scrutinizes it. And based on your past experiences, knowledge, beliefs, culture, other behaviors, your brain determines if you're in pain or not. The only reason why your brain would determine that you're in pain and cause you to have an experience of pain is if something is a threat to your survival. So essentially, pain is your brain saying something is threatening our survival, we need to pay attention to it. If your brain decides that what you're sensing is not a threat to your survival, you're not going to experience pain. But that's kind of the framework to think about it, is how much of a threat to our survival are these sensations coming into us from the environment, from our body? Our brain is going to determine if this is worthy of creating pain. So I just want to do a quick activity that's going to illustrate some of these points. So if everyone could close your eyes take a deep breath, and all I want you to do is feel the weight of this shirt on your back. Think about the texture, think about the pressure of the fabric on your back. Just kind of feel how it's sitting on your shoulders, on your neck, what kind of texture it is, and just really pay attention to that feeling. Now open your eyes. I'm sure all of you could probably notice that you had a shirt on, unless this is a Zoom call from home or WebEx from home, where you're taking things kind of casually. But I imagine most everyone can pick up the sensations of their shirt. If I'd asked you 5 minutes ago, were you feeling your shirt? You would say, absolutely not. Why would I be feeling my shirt? So this is just illustrating the fact that our brain is filtering information from our body at all times, and it really determines if this information coming from our body is relevant to our survival. If our brain wasn't able to filter all this information, we would pretty much go crazy because we would be overwhelmed with sensations throughout the day. Okay, so moving on. So pain is obviously a fairly complex subject here. I want to talk about a couple of different types of pain. So I'm sure you've heard acute pain and chronic pain. Acute pain being pain that happens immediately after an injury, and then chronic pain is kind of defined as pain lasting longer than normal tissue healing time. So I think generally 3 months is usually the cutoff for that. I don't find that as useful a definition. I usually like talking about maladaptive versus adaptive pain. So I'm just going to read off the definitions for these to get a better understanding of these two. So adaptive pain is helpful pain which produces behavior that promotes healing and recovery. It's a survival mechanism. Maladaptive pain is unhelpful pain that tends to be out of proportion to actual tissue damage and which persists long after the tissues have healed, so that the pain becomes the problem rather than the tissues from which the pain comes. So in this instance, pain is not a survival mechanism and is actually hindering our well-being. So I promised to talk about chronic pain a little bit. I strive to call it maladaptive or persistent pain because chronic pain just kind of has a bad connotation to it. So I'm going to refer to it as maladaptive or persistent. A lot of things happen when you're in chronic or maladaptive pain. But essentially, the best way that I find to understand it is that we have an overactive alarm system. So imagine you're walking down the street and you bump into someone's car. You're probably not going to set off that car's alarm system, right? That'd be normal. If this car alarm was overactive and oversensitive, you might set off this car alarm, and in this analogy, pain would be the car alarm. So it takes less stimulus to cross into the pain threshold. So if you look at this very quickly drawn PowerPoint graph that I did the other day with my cursor, I hope you can illustrate this point. So down at the bottom under normal, we have a lot of room for activity. So our normal resting kind of sensory inputs are well below this pain threshold. You can run, you can walk, you could even bump against the wall. You're not going to cross into that pain threshold. If you're in maladaptive or persistent pain, often what happens is you become closer to that pain threshold. So your resting state is almost in the pain threshold. And even sometimes you may be in pain throughout the day. You'd be above that pain threshold throughout the day. And it doesn't take much to push you into that region. I think what's important to understand here is what are all the factors that bring you from this normal resting level up to this elevated sensitivity. So we'll talk about that over the next couple slides. There's all kinds of things involved here, like peripheral sensitivity. So if you have increased amounts of inflammation, this is going to turn up the sensitivity of your nerves. Nerves in your spinal cord, like I said earlier, decide whether these signals are sent up to the brain. So if you're in maladaptive pain, you might be getting more signals than you normally would going all the way up to your brain. And overall, there's just changes in the brain wiring, which we'll touch on the next slide. So if we look at changes in the brain, these are often referred to as central sensitization. So you have peripheral sensitization, which would mean the nerves are just more likely to fire with a given stimulus, with bumping into a door, anything. Central sensitization involves a lot more of these complex brain functions that we kind of talked about with the same image a few slides ago. So central sensitization is associated with all kinds of things that will most likely keep you in a state of elevated pain. Things like fear avoidance, where you're scared of doing a lot of the same activities that you used to be able to do. Things like emotions get altered, so stress, anxiety, even depression can get triggered. If you're in pain for long periods of time, it's quite reasonable to develop depression, and quite understandable that that would happen. Another way I would like to think about this is that being in a state of pain all the time puts us in a fight or flight state. So if you've ever heard that, that's essentially our emergency nervous system kicking in. That's going to help us survive some kind of emergency. Think a bear is chasing you in the woods. So if your brain is always perceiving a threat to your survival, which is pain, that's what we defined pain as earlier, right? A threat to our survival. If our brain is constantly perceiving that, we're going to be in a state of fight or flight. What's going to happen now is we're going to have increased adrenaline, cortisol. Our body's not going to heal as well. We're not going to digest food as well because our brain and body is pretty much focused on whatever the emergency is. So all these other normal processes don't have to happen. Lastly, you can kind of see on the image on the right, some of these little flashpoints are all connected. What happens with central sensitization or persistent maladaptive pain, oftentimes the sensory pathways going all the way back to the spinal thalamic tract, these sensory pathways become very strongly connected to the areas responsible for producing pain. So anytime you get a sensation from an area, it triggers all of these areas in your brain to produce pain. And it can be really hard to disrupt this kind of link because your brain has become very well connected between these two regions. Okay, so I talked earlier about this slide here with the normal resting level and elevated sensitivity, and what might bring you closer to this threshold of pain. Well, these factors here all around this happy-looking dog here are things that have been found to affect pain. So things like nutrition, eating inflammatory foods can increase our sensitivity. Sleep plays a huge factor in pain. So you may think, well, I'm not sleeping well because I'm in pain, and that would be completely reasonable. But the converse is actually true. So the less we sleep, the poorer our sleep habits are, the more likely our body is to be in pain. Things like physical activity levels can increase or decrease your overall sensitivity. Your body's confidence, what you perceive is harming your body, is going to play a huge role in if you develop pain. So if you're very confident in what you can do, what your body can do, your body's not going to perceive certain signals as being a threat to your survival. And of course, stress and depression can also make you more likely to develop pain. That's why oftentimes persistent pain is treated very effectively with antidepressants. So if you look at this dog here, I would argue this dog is doing a few things right here, probably pretty unlikely that this dog is in pain right now. Okay, so I'm a physical therapist, so I want to talk a little bit about what a physical therapist can do to help people in pain. So as an outpatient orthopedic physical therapist, most of what we treat is people who are in pain following an injury. So it can be hard to really summarize what you do in a day or what your job is and summarize it down to a few points. But I'm going to try to do this. So essentially, we strive to answer a few questions when people come in to see us. People want to know what is the problem. So we do a thorough assessment of figuring out what is causing the pain. We look at strength of muscles, range of motion, movement patterns, do a thorough history of how this pain developed, and try to figure out what's causing this pain, what structures or patterns are leading you to be in this situation. We also answer what our patients will do, patients or clients, what can you do to help the pain? And then we'll help people understand what a PT does to help solve this problem as well. So taking kind of what we learned about pain, I want to talk about how PTs treat pain on a couple different levels. So the obvious ones are, we help you get stronger, we help you improve your range of motion, we help keep your tissues healthier. So by strengthening them, by working on things to improve the tissue quality, we can decrease pain because we'll decrease the amount of sensations that are perceived as damaging coming up to the brain. But something that's I don't think is always understood is what we do at some of these more central kind of brain regions. So one of my favorite things to do as a physical therapist to help people with is to help them become more confident in what they can do. So say every time you bend forward to pick up your dog, your grandkid, your child, a bag of dog food, every time you bend forward to pick up a bag of dog food, you hurt your back. It'd be quite understandable that your confidence in what your body can do is not very high at that moment. So what we like to do is improve people's confidence in what their body can do. We can do that through a variety of different ways by improving strength and range of motion, flexibility, things like that. But just by practicing the things that we're having a hard time doing, we can improve our brain's confidence that we can do them well, and that these things that used to be perceived as dangerous or a threat to survival no longer will be. So this brings me into kind of the second half of our talk, which is on resilience. I think resilience ties in really well to pain because everyone's going to become injured or hurt. We're all going to have painful experiences, but how are we going to adapt to those challenges? So this definition I really like is resilience is the capacity of a dynamic system to adapt successfully to challenges that threaten the function, survival, or future development of the system. If pain is a threat to our survival, what can we do to become more resilient, to decrease pain and improve the function and survival of our body? So briefly, I just want to talk about kind of one thought on what injuries are. So injuries generally lead to pain. This is really oversimplified, but I think it fits in well to this narrative. So essentially, an injury occurs when the force on our body is greater than it can withstand. So think you bend over to pick up your dog, and maybe your dog's gained a little weight recently. You bend over to pick it up, and you strain your back. There was too much force going through your back in that moment that it couldn't withstand, so we had an injury. So what can we do to minimize the risk of injury? Well, one way to think about it is we help our bodies produce more force. And we can do that through strengthening. So I want to give a couple examples of humans that I think are highly resilient people. So this is Stuart Jamieson. He is Scottish. You would never know it from this picture, but he was born with spina bifida, which is a condition which affects the development of the spinal cord. He was born with half of a rib cage. Doctors said he wouldn't even survive past 2 years old. After he survived past 2 years old, they said, you're not even going to walk. You're going to have to be in a wheelchair your whole life. Look what he's doing now. He's lifting hundreds of pounds off the ground and doing it very well. I would say this is a very resilient person. I'm sure he probably develops back pain at some point in his life, right? We all do. I would argue that he probably wouldn't develop back pain by bending over and lifting a bag of dog food off the ground. So it's going to take a lot more for him to become injured because he is so resilient. Next image, this is Shirley Webb. She's doing the same exact activity. I'm just going to read a quick blurb from an interview that was done with her, just to get an idea behind her story. So she said that my daughter Dorian asked me to join a local fitness facility with her just for the physical exercise. I had not really been physically active for the past 20 to 25 years other than just walking. Once we started exercising, I found it fun and invigorating. She goes on to say that before starting training, she was having difficulty negotiating stairs and arising from a floor when down, something that we hear really commonly. She figured out that strengthening was a way to become more resilient and help her with these activities. And now she's lifting hundreds of pounds off the ground. Again, she might get back pain, but it's probably not going to be from bending over and picking up her grandchild. And I don't really have any references or sources on this, but if she were to stumble and fall, her likelihood of breaking a hip is probably slim to none. She's a resilient human being. So, strength is obviously really important. There's so many other factors involved with pain and developing pain, as I've mentioned, but I want to focus on strength because I think it's often undervalued in an overall exercise routine. So I see people all the time who are really fit. They run, they might do yoga all the time, walk all the time, but people can end up with knee pain, hip pain, A lot of times it's because there's strength missing from their regular exercise routines. So a couple studies that illustrate this point. One study looked at reported measures of strength training for adults aged 65 years and older. And I found this really, really incredible. But adults who strength trained 2 times a week had a 46% lower mortality rate. That means compared to their peers who did not strength train, they were 46% less likely to die that year from all causes of death, including cancer and cardiac causes. In addition, the second bullet point down here, this came out just a few days ago as I was researching this. It looked at patients who had been diagnosed with breast cancer, type 2 diabetes, ischemic heart disease, and COPD, really serious problems. And they associated that higher levels of post-diagnosis physical activity associated with lower mortality rates in all of these conditions. These are people who are becoming more resilient and fighting off these really challenging diseases just by exercising and stronger. So, how do you become more resilient? I would argue that everybody sitting here already is a resilient human being. If you think about it, our bodies are programmed to heal themselves. So if you think back to a time when you may have scraped your knee, taken some skin off, what happened? Within a couple weeks, your skin was completely healed, right? You didn't even have to try to heal yourself. Your body did it on its own. And unless you actively tried to do something like pour bleach in it, it's going to heal on its own. There's nothing you can do to stop yourself from healing. So I think this just illustrates that we are naturally resilient creatures. Our body's programmed to come back from injuries. Our body's programmed to survive and thrive. So what happens? Why do some people end up in a state of persistent pain or persistent difficulties? Well, I think one of my arguments would be that we're not providing our body with the proper nutrition, with the proper things it has to do to survive. So things like sleeping well, exercising, socializing, taking care of your mental health, all these things that go back to that bullet point with the dog and with the depression, kind of stress, physical activity, all those bullet points that are related to pain are also ones that help us become a more resilient human and help us survive and thrive a little better. So that is it. I just wanted to give a couple resources from things that I've taken a lot of information from. A podcast called Pain Reframed is fantastic. It's done by a couple physical therapists, but they have guests from all backgrounds on there. Really informative, really interesting. There's a YouTube video called Tame the Beast, and it goes through a physical therapist kind of ideas of what pain is. And then also a Why Do I Hurt workbook. All of these people are probably going to explain this a whole lot better than I could, but feel free to reach out via email if you have any questions as well. So that is it. If anybody has any questions, feel free to put them in the chat bar or unmute yourself and ask away.
Sam, I'm just going to jump in here. Thank you.
Yeah.
Thank you so much for that great presentation, making a really, really difficult topic a lot more accessible, which is what we really strive to do. So that was fantastic. If anybody does have any questions, please go ahead and put it there in the chat, and we can get some of them answered. Yes, the slides will be available, and if you are if you want to put your email address in the chat area there, then we can get those to you, or better yet, let you know where they're going to be posted for consumption. Yeah. And while we're waiting for any other questions to come through, I put it in the chat myself, but 2 weeks from today will be our next Therapy Thursday. And we don't have a planned topic as such, but we're going to have an open forum for Ask the PT. So if you have questions that have been, you've got some pain questions, some injury questions, something that's going on for you that you have a question for a PT, that would be a great time to join us, and we can have an open conversation and hopefully share some information. Someone was asking if this is where you can ask a question. Yes, this is where you do it. I think that was Jane that was asking if this is where it is. So yeah, go for it. We'll hang on here for just a couple seconds, see if anybody else is gonna jump in here. Well, while we're waiting for any questions to come in, I'm going to thank Sam for all of his time. Oh, here we go. What, I don't know if you can read that, Sam. It says, what if you are running, no pain, then always same pain comes on in same location? Would you consider that chronic or acute?
Yeah, that's a really good question. So, acute pain would probably be the immediate aftermath of the injury. But if this is something that happens over and over again, you could maybe describe this as acute on chronic pain, so something that has recurrent episodes. But again, I wouldn't necessarily think about it in terms of acute or chronic. I think if you think about it in terms of adaptive versus maladaptive pain, if you're experiencing pain while you're running, and your body's trying to tell you to take it easy, to maybe decrease your mileage a little bit, that would be adaptive pain. If there is nothing necessarily wrong with your knee joints or muscles around it, and your brain has somehow associated running with pain, then that may be maladaptive. But it would probably take a thorough assessment of all the factors revolving around pain and running to really figure that out too. A good question.
Great, thank you. We're just about out of time here. I'd like to ask you just a quick question. So
Yeah, sure.
Yeah, I get a lot of patients that come in that I treat with fibromyalgia.
Mm-hmm.
That's a big one that kind of comes up time and time again. How can this information kind of help those patients? A lot of them unfortunately kind of get brushed off to the side as
Yeah.
this is all in your head and we don't know what it is, so we're just going to put this name on it, and this is what you have, and go on and good luck.
Yeah, it can be a really challenging diagnosis because I think it's not really well understood. I don't think we truly understand what causes these increased states of pain in patients who have fibromyalgia. One thing I have seen recently is that we're getting a better understanding that fibromyalgia is related possibly to a dysfunction in the immune system. And our immune system is responsible for kind of producing states of inflammation in addition to healing us. So our immune system kind of takes care of healing. Through the healing process, we have elevated states of inflammation. So it's a good thing in a acute kind of phase of pain. But I think what it sounds like what happens with fibromyalgia is that the immune system is maybe overactive, leading to this increased inflammation, causing increased sensitivity all over the body. I think I didn't really get a chance to talk about this too well, but some of the best things you can do for pain are just improving blood flow. So the happier your nerves are, the happier you're going to be, the less pain you're going to be in. So something that's always advised with fibromyalgia is aerobic, kind of non-high impact exercise. This is going to help bring a lot more blood through the tissues, bring a lot more blood to the nerves, and help them kind of become refreshed and not be stuck in this kind of inflammatory state. So again, really challenging discussion to have, and I think we don't fully understand it. But I think one way I like to talk about people is one thing I like to talk about people with is just keep your nerves happy. Do what your nerves like. Treat them well. So decrease inflammation when you can. Give your nerves as much blood flow as they can possibly need, because that's only going to help them.
All right, that's great. Thank you.
Mm-hmm.
Okay, so I want to thank everybody for coming out today. If you haven't done so already, we invite you to go over, if you're on Facebook, to go to UNC Therapy Services and like our group there, and you'll find out more about these events as they come up every other week. And yeah, but every other Thursday, first and third Thursdays of the month, you can use the same exact link that you hit today and join a new conversation about a new topic. So thank you everybody for coming out and enjoy the rest of your day.
Thanks, everybody. Thanks, Evan.
Bye.